Yeah. Let's talk a little bit about multidisciplinary work. What has been your experience where we kind of go back to the study? What's been your experience in working across specialties with patients in general for all of these cancers that we've mentioned? And where are some of the gaps that you've noticed, or what would you like to see happen in the future?
I think a multidisciplinary approach is absolutely essential in 2025 across tumor sites because our treatments are becoming so complex. A lot of times, the regimens don't follow the guidelines exactly, or the case scenarios don't follow the guidelines exactly. So I think it's really important that we have a multidisciplinary approach, particularly if there are features like variant histology, so not the traditional histology that's seen for each of these tumor types, talking about educating our colleagues that maybe are not at ASCO attending these meetings and getting the updates on these systemic therapies. So, talking to our urology colleagues and making sure that they know the updates on some of these drugs. I think we are in most centers, there is a very good multidisciplinary approach between, at least in genitourinary oncology, between our urology colleagues, our radiation oncology colleagues, pathology, radiology, nuclear medicine. And it's absolutely essential that that all teams are educated on the updates that are occurring with all of these trials. And, if there's a case, for example, the case management. Um, so, for example, the case based discussion that happened in RCC this past weekend was looking at, a multidisciplinary discussion. And to the point of localized kidney cancer and adjuvant treatment, there was also a discussion about in the metastatic kidney cancer setting, the role of cytoreductive nephrectomy. And we know that at this point, there is not good evidence for cytoreductive nephrectomy across the board, but it can be considered in select cases, either patients with minimal tumor burden, oligometastatic disease, or if they're highly symptomatic, but otherwise systemic therapy is the best approach upfront. But even for those cases where it could be considered, I think it's really important to have that discussion with urology to discuss the role of nephrectomy, to have the discussion with radiation to discuss the role of radiation to the primary. There are a lot of trials in this space looking at the true benefit of that, but I think that multidisciplinary approaches are absolutely essential. In bladder cancer, for most of the muscle invasive bladder cancer cases, we want the patient to see the urologist, the radiation oncologist, and the medical oncologist to talk about the option of bladder preservation and to talk about the option of cystectomy and with or without neoadjuvant chemotherapy.
Well, thank you so much for joining us on MD Newsline. It's been an absolute pleasure.